Thank you very much again. So there are three issues that I would like to address today in the current proposed LCD. The first has to do with molecular diagnostic test frequency must be no more frequent than the OPTN center-specific surveillance biopsy schedule. The second issue is that molecular testing should not be performed in conjunction with endomyocardial biopsies. And the third is that for a given patient encounter, only one molecular test for assessing allograft status may be performed. So to start with the first issue, and that has to do with the timing of molecular diagnostic testing only to correspond with the surveillance biopsy schedule. I would say that molecular surveillance is critical for patient management and should not be limited to instances where a surveillance biopsy would have been performed. Specifically, molecular testing facilitates the precision medicine that has evaded cardiac transplant recipient management because of the difficulties and impracticalities of biopsy surveillance. One of the holy grails in transplantation is to individualize or personalize immunosuppressive therapy. And to do so, we may want to perform more frequent rejection surveillance in younger patients who are at high risk of rejection, such as African American patients or allosensitized patients. On the other hand, we may want to do more frequent surveillance in older patients who are at low risk of rejection and high risk of toxicities. And this may actually help us wean immunosuppression faster in patients who do not need it. And this is why I believe that our surveillance should really be individualized to a particular patient based on their clinical risk profile. So I also think that molecular testing is really crucial because it enables us to detect graft injury very early before we see graft damage on biopsies. As you may know, by the time we see graft damage on biopsies, there's cell death, and this reflects the fact that immune activation and graft injury has probably been going on for at least days to weeks. So the advantages of molecular testing is that it is a very sensitive marker for early graft injury and can detect very early immune activation with tests such as gene expression profiling or donor-derived cell-free DNA. And this is an abstract from last year's ATC meeting, which showed that donor-derived cell-free DNA levels start to rise about 2 months prior to rejection on biopsy. So by using these very sensitive, non-invasive assays, we can actually detect graft injury much earlier than we could on biopsy. And so frequent surveillance could then enable us to titrate immunosuppression and hopefully augment maintenance therapy to prevent a full-blown rejection event from ultimately occurring and thereby personalize the care of our patients. Now this slide shows that patients who have rejection but no hemodynamic compromise have much improved outcomes to patients with mild or severe hemodynamic compromise. And so that's why it's important that we do early rejection surveillance so that we can detect rejection early before hemodynamic compromise occurs. We also know that most centers only do biopsies up till 1 or maybe 2 years post-transplant because these are invasive procedures that carry risk. But unfortunately, registry studies such as this one have shown that rejection may occur years post-transplant, especially antibody-mediated rejection. And this is why it's really important to continue rejection surveillance beyond the usual biopsy schedule, and non-invasive surveillance offers us the opportunity to do so. And so this is why the new ISHLT guidelines, which came out several months ago, state that routine tests and clinic visits are crucial for the success of heart transplant. The importance of lifelong follow-up by the transplant center is essential, and the purpose of the follow-up visits is to monitor for rejection and screen for adverse events. And so the reassurance of negative surveillance in this context is actually very helpful because it allows us to back off to reduce immunosuppression over time and prevent these long-term toxicities of our therapies. And I'd like to mention that the guidelines are not in the bibliography for the proposed LCD. Long-term biopsy surveillance is harmful. As we all know, more biopsies cause tricuspid regurgitation, which can cause graft dysfunction and graft failure. And also late biopsies often just yield scar tissue and are not helpful. We also know that biopsies can be very inaccurate. It's really quite a poor gold standard. This study shows that pathologists disagree almost half of the time on whether acute rejection is even present on biopsy. So biopsy is becoming less and less of a standard of care over time. And finally, our patients live very far away. At Stanford, for instance, we follow patients from all over California, Oregon, Nevada, Alaska, and Hawaii. And so it's quite impractical for patients to come into the center for biopsy. And this is really where the value of non-invasive surveillance lies. It's so helpful in being able to do remote draws to assess for rejection. So in summary, I think molecular testing is a suitable candidate to replace most surveillance biopsies and to allow surveillance testings when biopsies were not typically performed. And extended surveillance with molecular testing is very reasonable, not only to detect late rejection, but also to enable clinicians to personalize immunosuppression and to wean it over time and prevent long-term adverse events. So the second point I'd like to address is that molecular testing should not be performed in conjunction with biopsy. We now know that molecular tests are more sensitive than biopsy and can detect graft injury even when the biopsy is negative. And this is a figure from the DOR registry showing patients who presented with graft dysfunction who had a negative biopsy but elevated donor-derived cell-free DNA levels reflecting graft injury, and these patients were then treated for rejection. Cases such as antibody-mediated rejection can be very difficult to diagnose. Often the biopsies are negative, and we look at adjunctive data such as donor-specific antibodies, non-HLA antibodies, graft function, etc. But really where non-invasive surveillance can be very helpful is by doing assays such as cell-free DNA testing and gene expression testing to see whether there's graft injury. And if there is, we may go ahead and commit the patient to treatment. And with AMR, this is at least a 2-week treatment course, which can be highly toxic. And so we really rely on these adjunctive tests to help us cinch the diagnosis and commit to this intensive form of therapy. We also know that molecular testing can indicate the success of treatment of rejection. These are 2 studies that showed patients with acute rejection had a dramatic decline in their donor-derived cell-free DNA levels after treatment was started. And what we typically do as transplant centers is we repeat a biopsy after 2 weeks to see if our rejection treatment was successful. But we could actually perform a donor-derived cell-free DNA assay at the time of rejection and then several days or a week later to see if the rejection treatment was successful and therefore avoid repeat visits and further biopsies. And finally, I'd like to address the point that for a given patient encounter, only one molecular test for assessing allograft status may be performed. This is a recent review article that we just published in Circulation discussing all the different non-invasive tests that are available or in development and their clinical utility. Some of these assays detect immune activation, some detect graft injury. Some detect cellular rejection, some detect antibody-mediated rejection, and we may one day have non-invasive tests to screen for CAV. And I really think that these tests can be quite complementary and can provide data on different aspects of the immune response, on different post-transplant complications simultaneously, and that's really where their value may lie. And so I don't think that we should be limited to only performing one assay at a particular time. So in summary, these are my requested considerations for changes to the draft proposed LCD. The first point is that molecular diagnostic test frequency must be no more frequent than our center-specific biopsy schedules, and I would contend that molecular surveillance is critical for patient management and should not be limited to instances where a surveillance biopsy would have been performed. I gave several examples of how more frequent molecular testing can really help detect rejection earlier, can help wean immunosuppression, and thereby really personalize immunosuppressive therapy for our patients. The second point is that molecular testing should not be performed in conjunction with biopsy, and I would contend that there are some cases where simultaneous biopsy and molecular testing may improve the diagnosis in patients presenting with graft dysfunction and may help us monitor the efficacy of our treatment of acute rejection. And the final point is that for a given patient encounter, only one molecular test for assessing graft status may be performed. And as I just showed, I believe that molecular assays are complementary and can provide data on multiple aspects of the alloimmune response and graft injury simultaneously, and this is where their value will lie. So with that, I'd like to end my presentation, and I thank you very much for the opportunity to present today.